Good morning, everybody. In today's presentation, I will describe how computational modeling can provide insights into the causal mechanisms underlying heart sounds and how this information, together with statistical inference techniques, can lay the groundwork for AI powered technologies to augment the diagnostic accuracy of clinical techniques like cardiac auscultation. Cardiac auscultation, or the practice of listening to heart sounds for medical diagnosis, is a valuable centuries old tool in the physician's repertoire. Normal heart function is characterized by the S1 S2 sound pair, colloquially referred to as lubbed up sounds, and is associated with the closure of the mitral and the aortic valves, respectively. On the other hand, aortic stenosis is identified by a harsh mid systolic whooshing sound known as a murmur, and it is characterized by a diamond shaped crescendo decrescendo structure. Occasionally, the murmur may be accompanied by an early systolic ejection click. These audible characteristics can be identified by a trained physician to diagnose heart diseases, but the success of this technique relies heavily on his proficiency and listening acuity. Consequently, this safe and inexpensive skill suffers from poor accuracy and has seen an unfortunate decline among clinical practitioners. The question I want to address through this presentation is whether computational modeling techniques can help understand the causal mechanisms of heart sounds and guide the development of machine learning algorithms for accurate detection of heart failure. Our computational model consists of a circular section idealized aorta morphology comprised of the left ventricular outflow tract, the aortic annulus, the sinuses of Valsalva, and the proximal ascending aorta. The aortic valve has three leaflets which are modeled as zero thickness membranes. The 3D Navier-Stokes equations are integrated inside the aorta to obtain transient flow fields. Aortic valve dynamics are governed by a simplified equation which incorporates the effects of driving hemodynamic pressure and restoring tissue elasticity. Leaflet motion follows a reduced order model parametrized using constants relating to its mass and stiffness. The fluid and solid subsystems are coupled using a sharp interface immerse boundary method of Mittal et al. I generated a dataset of 26 cases of flow with healthy and stenotic valves to facilitate data-driven analysis. In each case, flow was driven using a flow rate profile based on physiological flow parameters shown in the red plot. The peak Reynolds number in each simulation based on the maximum inflow velocity and the aortic annulus diameter was set to 4,500. The bounds on instantaneous projected valve open area for the 26 cases are shown using the shaded region, and 3 cases are highlighted to describe qualitative hemodynamic differences between different types of tested valves. It is important to note that all stenotic cases simulated are examples of mild area stenosis based on AHA guidelines. In the first case, labeled healthy, all leaflets experience full range of motion. The aortic jet is largely symmetric about each sinus cusp, with mostly antegrade bulk flow colored in red. On the other hand, the two stenotic cases are examples of reduced mobility induced in 1 and 2 leaflets, respectively. In each case, the aortic jet tilts away from the stiffer leaflets, which also results in retrograde and recirculating flow downstream from the stiff leaflets as seen in blue. The stenotic cases are also associated with the generation of more turbulent vortical structures during valve closure. Once a description of transvalvular hemodynamics is available, the next step is to characterize acoustic wave propagation inside the subject's thorax, which are generated due to time-varying pressure fluctuations on the aorta lumen boundary. The bones, organs, and other surrounding tissue are assumed to constitute a homogeneous viscoelastic medium characterized by its density, Lamé parameters, and viscosity. Instead of solving three-dimensional partial differential equations governing acoustic wave propagation, the phenomenon is modeled in the frequency domain using a simple analytical approach. Under Fourier transform, the equation admits a free space Green's tensor, which enables calculating the elastic response due to a point pressure source recorded at a fixed monitor point in a homogeneous medium. By discretizing the lumen boundary into a number of pressure singularities, the cumulative response recorded by a stethoscope can be calculated using this summation, where f represents the Fourier transform of the time-varying normal force due to a point source. The stethoscope location is chosen to represent the aortic sounding port at the right second intercostal space. Here I plot the signal recorded by the stethoscope over 5 cardiac cycles in each of the 3 cases I previously described. You can also hear these sounds at your convenience by following this URL. To understand what's going on, I zoom into the first half of a cardiac cycle and take a closer look. In each case, the solid red plot indicates the recorded sound. Additionally, individual leaflet displacements are plotted using dashed lines for context. In the healthy case, we do not see a prominent response until the leaflets are more than halfway closed during flow deceleration, and this is the S2 sound. Next, in each stenotic case, the signal shows a crescendo during acceleration and early deceleration, while the leaflets remain mostly open, followed by a decrescendo extending from mid-deceleration until the valve leaflets are completely closed. A prominent feature in both these cases is an absence of an S2 sound, which is characteristic of aortic stenosis. Additionally, ejection clicks are observed during early acceleration when the stiffer leaflets first reverse direction after maximal opening. Thus, our simplified computational model is capable of replicating characteristic acoustic features of healthy and stenotic aortic valves. As a first step in statistical inference, the dataset of stethoscope recordings is balanced by synthesizing additional signals so that there are equally many signals corresponding to healthy valves, shown in blue, as there are stenotic valves, shown in red. Each signal is then normalized to unit magnitude and centered about the ensemble average of the dataset. Next, for dimensionality reduction, the principal components of the normalized signals are calculated via singular value decomposition. By projecting a generic signal AI onto the first p right singular vectors, its feature vector omega can be constructed. The number of features p is typically much smaller than the number of time samples n, and its optimal value was determined to be 20 through cross-validation using a linear discriminant classifier. The 20-mode reconstruction of the dataset, along with the class-wise average signals, are shown in this figure. It is observed that healthy signals in blue typically peak around valve closure, so t equals 0.35, whereas stenotic signals peak early during deceleration. I plot the 5 PCA modes most relevant for classification and their respective contributions to the dataset. For each mode, I calculate the ratio of the mean squared norm of the stenotic class to that of the healthy class. This energy ratio indicates whether a given mode is more dominant on average in stenotic response compared to healthy response. It is observed that modes 8 and 3 are more dominant in healthy class with energy ratio less than 1. On the other hand, energy ratio is greater than 1 in the remainder modes, indicating dominance in the stenotic class. The physical processes represented by these modes can be understood using spectrograms of the individual mode shapes. Modes 8 and 3, which are dominant in healthy sounds, show a lower pitch response in the 10 to 30 Hz range towards the end of systolic ejection. On the other hand, modes 20, 13, and 17 are dominant in stenotic sounds and show a more broadband mid to late systolic response in the 10 to 50 Hz range. These modes also show peak amplitudes between t equals 0.15 and t equals 0.3, with lower amplitudes on either side, indicating a crescendo-decrescendo signal. From these results, I infer that the lower PCA modes describe sounds associated with larger scale events, such as valve closure, and are therefore dominant in healthy sounds, while higher modes describe sounds due to systolic turbulence and correlate strongly with stenotic murmurs. Finally, I present classification results using a linear discriminant classifier in this figure. The cyan and red bars represent histograms of LDA projections of healthy and stenotic signals from the development set. These histograms are used to define a discrimination threshold to minimize class overlap. The corresponding projections from the test set where 10 new simulations are shown using the blue and the orange bars, respectively. As observed, the projection vector and threshold computed from the training set can accurately discriminate healthy signals from stenotic ones, indicating accurate detection of aortic stenosis. But wait, there's more. We also tested this process on a patient-specific dataset of 84 cases generated using CT scans of 6 patients and saw similar performance in terms of valve failure detection. To summarize, computational modeling and machine learning can lead preliminary analyses into developing cardiac monitoring technologies. I showed how differences in jet hemodynamics lead to physiological and pathological systolic heart sounds. These differences can be exploited in a statistical sense to predict valve health. Such a method based in exploiting the underlying causal mechanisms is robust to variations in patient morphology. If you want to know more, details about this work can be found in my recent Frontiers in Physiology paper. Thank you.